Good afternoon to everyone, and thanks for joining us. Well, obviously at the weekend you had three lions and the lightning seeds. Today we've got the first lightning talk and two lions in the shape of Fiona Matthews, who's Dean of Research and Innovation and Professor of Epidemiology at Newcastle University, and Martin Wilson, who's Chief Operating Officer for Newcastle upon Tyne Hospital's NHS Foundation Trust. And you'll quickly see why we've picked this as our opening Newcastle Health Innovation Partners lightning talk, because I think the integrated COVID hub Northeast has been a great example of collaborative working led through the trust. So without further ado from me, over to you, Martin. Thank you.
Thank you very much, David, and welcome everybody. So our journey around this predated COVID, and it was in recognition that across Newcastle, we have some fantastic organisations, indeed outstanding, but together, like the NHS Trust, but together they're not sufficient to address the kind of health inequalities challenges that local people face. Many people recognise these charts, that on the left, compared to the England average, people in Newcastle have 5.5 years fewer healthy life expectancy, and in fact die about 1.7 years earlier than the England average. And within the city, we've got massive inequalities with a 10-year difference in healthy life expectancy between people who live at two different ends of the metro map around them. We'd recognise through civic partners across the city that actually access to healthcare is only 20% of the story, and that 80% of population health is about things like having homes, jobs and friends. So we came together about 2 years ago now and created Collaborative Newcastle, which is a partnership of the strategic partners you see on that page from both the NHS and local authority, from the universities, primary care and the voluntary and community sector, about how can we collectively work together to improve the health, the wealth and the well-being of people across the city in ways that would really, truly transform the future that we all face. Together we've got three big priorities. One of them is around health and care, one of them is around growth and prosperity, and the third one was around carbon and the climate issues. If you fast forward a little bit though, and in fact rewind the clock to January of last year, Newcastle hit the headlines that we took the first patients with COVID anywhere in the country. 2 people came up from York, very end of January, and came to our infectious diseases unit. Over the coming weeks, the numbers of cases of COVID across the city rose, and indeed by the end of March, we were having big conversations about what the future looked like in terms of the pandemic. Fiona and I started to work together around what the modelling would look like, not just for Newcastle in terms of how busy our hospitals would be, but indeed the whole of the region. And by the time we got up to about having 60 people in the RVI with COVID, of whom about 20 were intensive care, it was looking very likely that we were on a course for something quite cataclysmic happening. And we were asked one night via text by the regional director to look at, could we create a Nightingale hospital? And indeed, the modelling work you see in the chart there suggested that across the region, we might become overwhelmed. So within 4 weeks, we did create a Nightingale hospital, and we showed how we can use the value of big organisations in the system to do big things that would really help. What then happened, and the chart on the left is saying how many people in hospital here in Newcastle had COVID. And at the first peak of that yellow bar, which is around the Easter, is when we had the most number of people in the hospital and we were ready to open the Nightingale Hospital. Fortunately, it wasn't required. And by the time we got to the end of July, the 21st of July was the first day we actually found ourselves with no patients with COVID in the hospital, which was great encouragement. But we began to reflect on the experience we've been through and how did we need to behave differently as a system. And at that time, we reflected that there had been insufficient availability of tests for COVID, that there were big challenges around the national model of test and trace. And there were big opportunities for us to respond differently, particularly between local government, the NHS and other partners. And Professor Eugene Milne, the Director of Public Health, and I and some colleagues pulled together an outline around how we thought we might be able to do things differently that links to what you see on the right, which was the Northeast's collective strategy for how to come through COVID, which was the crucial role both around data intelligence, about influencing human behaviour, expanding our capacity to do tests, protect vulnerable people, localised track and trace into the local system, and eventually, when a vaccine was developed through research trials, to be able to roll out the COVID vaccine. We put together an idea for what that could be, and it became the integrated COVID hub. We pitched this to ministers on the 21st of July last year and said that what we would like to do was to build something that had three key elements. Firstly, for the first time ever, an NHS-run mass lighthouse laboratory that would do COVID testing at scale. Secondly, to provide a function that would work with the 12 local authorities across the region to support them in coordinating and responding to the pandemic as it developed. And also an innovation lab that would help us to improve COVID clinical science and diagnostic testing. Ministers were excited by our proposal, and we had come together as a joint group of organisations, including universities, the council and ourselves, to pitch that idea. So if we can now fast forward almost a year from that initial idea to where we've become, we built in Gateshead, in the Baltic facility just behind the Sage building, a mass NHS lab in under 5 months. We went out and recruited a workforce of over 700 people to work in that lab and deliberately targeted those jobs at disadvantaged communities across the city and the wider region for people who previously wouldn't have seen the NHS as being an employer that would be particularly attractive or recruiting for them. And we've had great success. We have been able to increase the diversity of our workforce overall and to target particularly disadvantaged communities. That's really important to us because for all those reasons around health, wealth and well-being that I talked about at the start, we do believe there'll be a huge legacy impact about creating those jobs. And indeed, we've got a collaboration with Newcastle University and a 1,000 worker study to measure that impact. The lab is now open 24 hours a day, 7 days a week, busier than it's ever been. We do about 60,000 tests per day, which is more than 20 times what the combined NHS does across the region on a day. And we're just later this week, we'll get up to having tested 2 million people. And around 6 weeks ago now, we started testing for 4 different variants within the lab as well. And we hope that in the next few weeks, we'll get the go ahead to expand in partnership with Cumbria University, doing genome testing, genome sequencing as well. The second element of the ICHNI 3-part mission was the Innovation Lab, and this is very exciting for us. It is helping us to test new tests for COVID, including point of care testing and other arrangements. We're doing that nationally. We are collecting a biobank of samples, so where we are finding people either through the Lighthouse Lab or community cases, where there is positive COVID cases, we're able to take samples, put them into our fridges and freezers and provide those to people who are developing new tests. The Innovation Lab have been coming into their own in terms of helping us introduce new technologies, including rolling out variant testing like the Delta test, but also helping us do things which are going to sustain long beyond COVID. For example, a big proposal around how we might bring in wastewater testing. So this is putting units into sewerage pipes right across the city and across the country to detect community levels of COVID and potentially other infectious diseases. And finally, for me, the Coordination Response Centre, so this is the bit that works into local authority. We've put that on the top of the Lumen building. We recruited a team of staff, very few of whom had NHS or public health backgrounds, and have used them as a flexible resource to support all the local authorities across the region. They've now taken on contact tracing calls for many of the local authorities. And at the heart of the Coordination Response Centre is the crucial role of data analytics that supports how we can respond very dynamically to what comes across. And so I'll hand over to Fiona to say more around that programme.
Thank you, Martin. As Fiona's putting her slides up, if I could just remind the audience that if you do have any questions or comments, please feel free to use the chat function.
Thanks very much, David. So moving on to the analytics, as Martin said, that initially, at least, the models around thinking about COVID was a request about the region and the region's hospitals. So how do we go about doing that? Well, this is the curve with the blue points here are the points that we had at that time. This is clearly sort of it's a really steep increasing exponential growth. And what we had to do was attempt to put on the rest of the slide, understand the rest of that picture. And this is the model that was introduced at that time, that the sort of slightly lighter color blue dots are the data that we didn't know at that time. And you can see here that actually, whilst we predicted a peak, the impact of the lockdown on that peak was actually it brought the peak down quicker than expected. But the other thing you notice is that actually we never really got down to a really low level that one would have expected if you had an infectious disease that ripped through the population and required immunity. But admissions to hospital are not people in beds. Unfortunately, individuals, once they're in a hospital, will be in a bed for a variable amount of time, and that can range from only 1 or 2 days to a month or more in a hospital bed, and you don't know that when they're admitted. And so what we undertook was modelling of those hospital admissions and the uncertainty around that curve, together with the uncertainty as to when individuals will stay in a hospital. And this is the model that was undertaken for the 7th of April. And as Martin said, you know, that there was going to be the peak early in April, and then hospitalizations peak about 3 weeks after cases in the original first and second waves. We don't know how they're going to act for this one. So moving on, that was useful for the region in terms of the health service, but we need to understand a lot more about COVID from the data that we have. There's a lot of data analytics out there. And so what we do within our analytics group is not actually redo any of that data analytics. We provide context to it and information, but we don't, we add to and supplement what's already there for the ICHNI group, but for, as Martin said, for heads of public health, councils, trusts, etc. So the sort of things we provide on a very basic level. This is the third wave of COVID cases, and you can see that there's as a region. Initially, at least, we were okay across the region in terms of the case numbers. But different areas move in different speeds. Around this stage, there started to be this, suddenly North Tyneside was in the news about the lockdown that never was, and the miscommunication about what that was really about when North Tyneside leapt to the top. But gradually, over the course of this third wave, all of the other areas have gradually, around the region, has been in the news about the fact that we're now higher than the rest of the region. Recently, we've expanded our area, so now we also include Cumbria in the regions around Cumbria in these reports now. But as you can see, we're not doing so well on this third wave at the moment. But is this going to actually impact on the cases in the hospitals and the planning that needs to be undertaken? And so that's when we start to think about other things. So this is the average ages of cases over time. Obviously, the first wave was really predominated by a function of who we were testing, which was people in hospitals, and also the stage of the epidemic and the susceptible population to actually have a really high average age. But here we've got age of the cases was coming down over recent days. It started to go up again, which is a worry because we know those individuals are more likely to be hospitalized. But the other side we can look at is the trends in excess deaths. So this is for each region. This is across this year. You see the first peak, there was an excess of deaths across all of the regions. And it will meander around. Excess deaths do every year because different things come in at different points. But over the last week, we've seen a start of an increase in excess deaths. And why that's concerning for us is that actually that predates hospitalizations. These aren't COVID-related deaths, but there is a notice that people do tend to avoid going to hospital for normal things, sort of when case numbers start to go up, and that will cause excess deaths for other reasons. But clearly, for this region, the biggest way that we're going to stop this epidemic is actually the vaccine rollout. So we've been thinking about how the vaccine rollout works across the region. Obviously, there's the national policy, which is an age-related policy. So we fill out the age curve as we go through the days and weeks. But there are differences in vaccine rollout across the region. And this harks back to what Martin was saying about, as a region, we know that there are inequalities across the region. And then vaccine rollout is not supposed to be obviously related to any of those things, but we do know that different communities need different messages in terms of understanding the inequalities and reducing inequalities in vaccine rollout, which in turn will reduce the inequalities in terms of those who get cases and the hospitalizations that follow. So we monitor those inequalities and we help different regions understand those inequalities. And this is just two of the inequalities here, the deprivation quintiles. Some of the most deprived populations across our region have a higher proportion of unvaccinated individuals in them. And also there is also a well-known ethnicity difference in terms of the take-up of the vaccination. And what this information can do is we could then provide within the CRC that there's, going out to different communities and talking to those communities about their issues about the reluctance to take up the vaccine and try and resolve those issues. And we've been developing this aspect called the sort of a vulnerability index, a static vulnerability index, which takes different regions of data from different regions in terms of the socioeconomic makeup, the ethnicity makeup, the comorbidity that they already have, and superimposes them all together to identify areas within our geography. This is Newcastle, to identify areas where we can actually pinpoint a number of aspects. A population who's highly susceptible to the virus, on top of that, a population with a low coverage of the vaccine, and also a populations where they are not undertaking the case. They have not got a high take-up of cases being tested. And you can actually then identify and pinpoint areas around the regions where there might be a vaccine bus is needed, or a change in the mention, or a change in the messaging around either testing or the vaccine take-up to really target populations and reduce what we see. As I mentioned, we don't actually replicate work that's done by others because that's not useful. We create those pictures for other people to understand them. And this was the national predictions for the third wave a couple of weeks ago. In actual fact, this third wave is at the moment looking like it's arriving earlier and is being faster than that predicted by those national predictions. But we can then track our existing data on this and see whether the third wave does follow this for the different areas, and hopefully the bed occupancy will hopefully be less than that predicted by that model. So we continue to do our trust-based analysis that we've been doing all the entire time. Once there's more than a few cases of COVID in the hospitals, we model whether we're going to run out of beds and when that might be. But the COVID epidemic, the third time round, is very different. And one of the most recent things that we've been asked to do is model staff absences, because it's not necessarily people in beds that the problem, it's the staff for the beds that is the issue. And at the moment, this is confidential information, so I've removed the y-axis, and I'm not saying which hospital it is, but what we do is provide the hospitals with this information as to what proportion of their staff are off, and this is based on the case numbers in the area of the hospital. And we can give them an indication as to when 10%, 20% or 30% of their staff will be off due to test and tracing and in terms of the contacts. And this is what's been in the news about, the impact of the COVID epidemic in terms of the knock-on impact that has. So just finally, this is called a third wave. I mean, notionally, we could possibly be a fourth wave within this region. The first wave looked very small due to data analytical issues. We weren't testing anyone. This wave is very big, and the impact of what that's going to have in terms of our hospitalization is still a little bit unknown. And that's what we do within the analytics. We try and understand from a region what this means, and then get those data and analytics out quickly so that the individuals can respond and change practice based on things that are happening in our region today to understand what's going to happen tomorrow. Thank you.
Thanks very much, Fiona and Martin. That was really interesting. I've also got up the participants list, so if anybody does want to ask a question in sort of real time, just put the hand up, hand function. Don't raise it on the screen because I won't be able to see you. Just whilst everybody's pondering and digesting that, if I could just ask you both maybe a sort of a double-headed question. Firstly, Fiona, that there's sort of been a bit of talk about the bigger the peak now, the lower the peak might be in winter. Would just be interesting to get your comment on that. Is it just simply a temporal function, and there isn't time for another winter peak, given the fact we've not even peaked out on the current wave? And secondly, I don't know whether either of you can comment, but obviously there's been talk about winter flu coming along, and as I understand it, winter flu often originates down in Australia, and I know they've kept a lid on their cases down there quite a lot. But is there any data about some unwelcome synergies or comorbidities that occur in the context of people having had COVID and then getting winter flu, and what might be we expect in that regard? So Fiona, do you want to just kick off about this sort of reciprocity on the peak now versus the winter peak?
Yeah, so the original models always had a sort of a peak in late July and a peak in after the schools go back in September. Whether we will still get that peak once the schools and universities go back in September is a bit of an unknown. That will depend on how much as a region we do actually get to that herd immunity, that so-called herd immunity point via either vaccinations or it ripping through the population as it's currently doing, and whether a new variant that may well be around in early autumn is actually still, the immunity is still there for that new variant. So there was always a plan that there would be one peak and there's possibly a smaller peak in September. Whether that's, I'm not 100% certain that that's still going to happen, but but there is always the opportunity, the possibility. So that's as much as I could sort of say about that one. With regard to winter flu, it is a tricky issue because, as you say, we've actually managed over the course of the pandemic to actually really keep winter flu. We didn't have winter flu particularly badly last year. Neither did Australia last year or this year. And at the moment, there's predictions of flu, and there is predictions of yes, we will get back to having winter flu this winter if we've completely opened up. How much people's change in behavior will actually resolve some of those issues about winter flu is a really interesting question, because obviously, we now know that actually you can keep a lid on winter flu if nobody contacts each other and you don't come into work if you're sick and things like that. So whether that will persist is a different matter. So yeah, I mean, that's but nobody's really had a chance or an opportunity to see the interaction between COVID and flu because they've been done they haven't been coexisting yet.
Thanks, Fiona. That's very clear. So any other points or questions or comments from any of you all out there? That would be good to hear. I mean, Martin, I guess just whilst everybody again continues to ponder, I guess Fiona's point about excess mortality and people not wanting to come into hospital because they're frightened of catching something. I mean, just any comments or observations on that? I'm sure, I know from my involvement in the Trust Board that you're obviously grappling with the waiting times and the waiting lists. I mean, just some sort of general comments really, because we're hearing that quite a lot now in the news as well about waiting times going through the roof.
Yeah, I mean, it's generally unprecedented times, isn't it? So we find ourselves in the A&E department, we're seeing about 20% more people coming in each day than we did before COVID. We're speculating what might be driving that is that the consequences of people having a year locked in their houses and their health will have deteriorated. Is it driven by perceptions or the challenges of people's ability to get into primary care, where again, they're dealing with 15% more contacts every day but with many of those people being managed by telephone as opposed to face-to-face, and how does that all expose itself? And we've got this huge backlog of patients. So there's now about 85,000 patients across the city of Newcastle, or in the trust from various parts, that are on our waiting list for elective care. And at the moment, we're very keen to get through those as quickly as possible. But we've got those real workforce challenges that at the moment, a number of NHS staff, like in other industries, are having to isolate because they've come into contact with others, and that reduces our capacity to do it. And we've got some human patient behaviour where people are still a little bit diffident about coming forward to receive care, with that perception that hospitals are not particularly safe. The good news is that the hospitals are very safe. There is no evidence of transmission at all happening in our hospitals. It's a good place to be. And actually, the mortality that we're seeing in Newcastle for the people that we do care for in the RVI and the Freeman who've had COVID is really amongst the very, very best anywhere in the country. So some complex dynamics about incentivizing the right sets of behaviours for people to access healthcare.
That's super comprehensive answer. Yeah, and actually that point about the low mortality in the hospital is really worth emphasising. It's quite striking, actually, from what I can see. Claire Abley has a question, got her hand up. This might be the last question, actually, because I'm really keen that we keep to time and finish at 2:45. Otherwise, people will want to come back if these become drawn out. So, Claire, in you come with your question.
Yeah, my question was about the future, really, and the extent to which we can we plan? Are we planning to continue providing all these services that exist in the hub and all the associated services? Because it's massive, isn't it? Are we planning to provide that on an ongoing basis, or is it possible to plan, say, how long this will be needed?
Yeah, thanks. Martin, did you want to tackle that one?
Yeah, happy. Thanks, Claire, for the question. I mean, we would really like to keep this kind of functionality here in the Northeast for a few reasons. One of them is that we think we've learned things about how we manage COVID that we might want to apply to other diagnostic tests, diagnoses like flu, as Fiona alluded to. So do we have that kind of testing capability? But secondly, we recognise the huge benefits of the economy about creating the jobs. So one of the benefits of the Innovation Lab is, can we entice industries to work in the Northeast? Because not only do we have the infrastructure and kind of relationships that make it very special between the universities, the NHS and industry up here that make it a good place to be, but we've also shown that we can recruit the skills for people to want to take on these jobs. So can we become a bit of a base for more STEM type careers between the health and care space and the region? And there's also that opportunity that there is a new organisation called the UK Health Security Agency, which has just been established. It's got a new chief exec in one of the deputy chief medical officers. She was up last week visiting us to see what we're about, and we're very keen to see can the kind of infrastructure and functions and the appetite for an organisation like Newcastle Hospitals with its partners that typically wouldn't be in the public health space, to see this as being the future and something that'd be useful to their strategy. So fingers crossed, we'd love to keep this going, but a lot of it will depend on our ability to do great work and to sell a compelling vision about why we're all in this together and want to innovate to take this on to the next stage.
Super, Martin. Thank you. Great.
Thank you.
Thanks, Claire, for your question. And also, there's been quite a bit coming through on the chat line, and Fiona's been doing a brilliant job answering in real time to a very good questions actually from Helen and from Elizabeth there. The other thing I would just add in response to Elizabeth's question about influencing human behaviours is that we know that some people do have vaccine phobia in terms of things like needles, and there's quite a literature out there. And I know people in the psychology department, Claire Lomax and colleagues, have been quite keen to try and deliver online CBT, which has been shown to actually reduce that phobia, which would hopefully allow more people who are genuinely frightened of coming forward to have the vaccination carried out. Fiona's question or answer obviously is a little bit more, I think, a broader issue, which others also experience as well, about changing behaviours. So that's great, and thanks for your comment there, Claire, Owen, as well. That's much appreciated. I'm sure that Fiona and Martin appreciate that. So it just remains for me to thank all of you for coming along and giving of your time in this half hour, but mainly to Fiona and to Martin for their time in putting together such a really interesting combination and offering there. Some really great data, some really great work that's leading the line in the national effort to try and beat the pandemic. So thanks. Tell your friends, tell all your colleagues who've turned up here about these lightning talks. And you've heard from Peter about the upcoming talks, and we'll try and advertise those as widely as we can. So thanks again, stay safe everyone, and thanks again to Fiona and Martin.